Thank you for coming. In honor of National Immunization Awareness Month, highlighting the importance of vaccination for people of all ages, we'd like to welcome Dr. Caplivski for his grand rounds on travel medicine in the era of emerging pathogens. Dr. Caplivski received his medical degree at Yale University School of Medicine, completed his internal medicine and infectious diseases fellowship here at the Mount Sinai Hospital. He is also a graduate of the Borges course in clinical tropical medicine in Peru, with first-hand experience treating a wide spectrum of tropical diseases. He is currently Associate Professor of Medicine in the Department of Medicine, Director of the Mount Sinai Travel Medicine Program, and for over the last 10 years, Co-Director of the Medical Microbiology course in the Icahn School of Medicine. Please join me in welcoming Dr. Caplivski.
Thank you so much. Always a pleasure to speak to this audience, and wonderful to get an introduction from Colin, one of our former medical students here, now Chief Resident. So, I was looking back about a year ago, and we had a fantastic grand rounds from Dr. Weaver, who came from the UTMB system to talk to us about Zika virus. And it was a really new information at the time. And I hope in today's talk to give us a little bit of an update of what we know since then in 12 months that have passed, but also to talk about this general trend of emerging pathogens and the way that they affect our care of patients. I have no financial disclosures to talk about. And I usually start with this slide about travel medicine as a subspecialty. The guidelines published by the IDSA in 2006 are now being updated, but they kind of set forth a set of principles for us to think about travel medicine. Certainly a much older specialty than that. But it really does combine many subspecialties in medicine. We certainly think a lot about it in infectious diseases. But there are other disciplines, including pulmonology and those that think about high altitude and the response to lower oxygen tension, that also are very important for this subspecialty. But I basically kind of divided between pre-travel and post-travel evaluation. And among our pre-travel patients, we're usually starting out with an understanding of their basic immune system deficiencies or problems, because more and more we are seeing patients who are traveling abroad who have HIV, who have Crohn's disease managed with biologics, who have transplants. We have to think about those in particular with some of our live attenuated vaccines like yellow fever. We have some very itinerary-specific recommendations for some folks going to Peru, for example. They're really going to just be in the highlands, so they wouldn't be at risk for some of the insect-borne illnesses like yellow fever. The vaccinations are a big part of what we do, but we also talk about insect prevention measures, anti-malarial prophylaxis, food and water safety, and management of travelers' diarrhea, since those are common problems. General safety refers to the fact, by the time we get to the end of a pre-travel visit, it can sound very scary to go to a place that has some of these infections like malaria. But the truth is that the overall risk to travelers is much more significant from car accidents. So we try to remind them about wearing seat belts and those kind of things. In the post-travel evaluation, we're much more attuned to this, I think, as a medical community in the era of these emerging pathogens. But it's important to remember that sometimes the symptoms of fever or rash may be unrelated to travel. So we want to keep a couple of lists in mind in terms of causes of those symptoms here, as well as those that might be related to travel abroad. Incubation periods have been very useful in separating some of these possible etiologies. Some of the viral pathogens like dengue, chikungunya, and Zika tend to have fairly short incubation periods. So between 1 and 12 days, most of those patients will present with their symptoms of fever, rash. But with falciparum malaria, that can be a longer period, and certainly with some of the non-falciparum malarias that I'll mention at the end of the talk, like Vivax and Ovale, those can really be quite long, even months before someone has their first symptom of fever. Typhoid, Salmonella typhi, is typically around 2 weeks, but sometimes longer. And hepatitis A, which fortunately we don't see as much anymore with immunization that has become routine for children, is usually a longer period, up to a month. In terms of the emerging pathogens that we've seen over the past few decades, I was a resident here in 2000 through 2003, and around 2002 was when the Sars outbreak began, and that was a really novel event. It was a new coronavirus that was an example of a zoonotic exposure from animals to humans, where we had coronaviruses usually we thought of as the cause of the common cold and generally a mild illness. But suddenly we were seeing patients initially in Asia where they were getting very, very sick and dying. And this was traced back to some of the food markets in southern China where live animals were in close contact with humans. And I think SARS really demonstrated how quickly things could move across international borders and the global impact of an outbreak that begins in southern China, moves on to Hong Kong, and then spreads quickly throughout the world. So lots of implications for travel and for healthcare workers in terms of infection control procedures and the way that we started to evaluate travelers in the ER. Polio, unfortunately, is not on our list of eradicated illnesses. We have a couple of really good vaccines for that, but a lot of places where it's been difficult to implement vaccination, so we've seen recurrences of polio. Dengue was on the wane in the 1950s. We really had excellent mosquito control at one point, but then we've seen a resurgence in dengue throughout the Americas that kind of modeled what we've later seen with both chikungunya and Zika. So chikungunya is an illness that we did not really see in the Americas before the last few years, but because of the prevalence of the Aedes albopictus mosquitoes, the range of infection has extended. MERS is a fairly similar virus to what we saw with SARS. It's hard to keep track of all these if you think about the last couple of decades. But MERS was a Middle Eastern coronavirus that was a very severe respiratory syndrome. And I'll show a little bit of detail of these epidemiologic curves to show what happens when there's a secondary outbreak. Ebola, as you'll recall, was an unprecedented outbreak in terms of the numbers and scope of that outbreak. And it really did impact the way that we evaluate all of our patients. Avian influenza is one of the organisms that we're very concerned about because we've seen how quickly the H1N1 swine flu moved throughout the world population. Avian influenza is a very highly pathogenic virus that fortunately does not transmit readily from one human to the next, but it's certainly something we're monitoring carefully. Again, measles, another example of a vaccine-preventable illness where we've seen outbreaks. Most recently, you'll probably recall the Disneyland outbreak, where we had a multi-state outbreak with children that were unimmunized and that were exposed to measles. And then finally, I'll spend a little more time on Zika so we have an update in terms of the way that we are evaluating data on this virus. So here's a little bit more about the outbreak with SARS and the rapid uptick in the number of cases that eventually did curtail, as well as some of the flight patterns and the way that the virus spread from one part of the world quickly to basically all the rest of the world. In terms of MERS, we saw an initial outbreak in the Middle East, but then there was a secondary outbreak in South Korea that was interesting because it also highlighted the importance of hospitals recognizing novel infectious syndromes and recognizing that this was in fact a traveler that had come to South Korea but started a secondary outbreak, including within hospital settings. The Ebola outbreak, as I mentioned, was a tremendous number of cases that we had not really seen in the past. Most Ebola outbreaks had been much smaller and had not crossed so many international borders, including having us see healthcare workers infected here in the United States. But the viruses of chikungunya and Zika, I think, are very instructive in terms of understanding the way that vector-borne viruses are behaving in the world. So chikungunya, as I mentioned before, 2013 was really not described in the Americas. But once it arrived, we've seen over 1.5 million cases. And these are the vectors. So this is the Aedes aegypti and Aedes albopictus vector. And the Aedes aegypti is present in many parts of the tropics, the Caribbean, some of the southern United States. But Aedes albopictus has a much wider range of flights or of endemicity. So that's a concern if it serves as a vector for some of these viruses. So its distribution in terms of the chikungunya outbreak, it was described initially in parts of Africa in the 50s, and then later we saw outbreaks in Asia. And then there were some interesting cases in Italy that were reported in the literature again associated with these Aedes albopictus mosquitoes. But once it hit the Caribbean, it was really quickly spreading across the Americas, and it served as sort of a precursor to what we would see with Zika virus. Now, chikungunya, fortunately, tends to be a virus with fewer implications than Zika. But for those that did suffer it, it was a debilitating illness at the time. So some of the fevers and rash were fairly nonspecific, but the arthralgias, the really severe joint aches, were really quite profound. The name comes from an African dialect that means to become contorted from that pain. And some of those patients did in fact persist with those joint pains for many weeks or months. Zika virus clinical disease, when we do see it, can overlap a lot with these other viruses, with dengue or chikungunya, because all of them tend to be a febrile rash illness. What's a little bit distinctive about Zika is that it tends to have a conjunctivitis, so there's an eye inflammation that's, when present, very useful diagnostically. One of the things we have learned, however, is that it's an asymptomatic infection in upwards of 80% of the population, and that's from some of the outbreaks that we saw on Yap Island. It's a short incubation illness, and it's a short viremia, so that leads to some diagnostic challenges as well. So here was the spread of Zika virus as far as we understand it. Dr. Weaver described initially how in the Zika forest there were researchers working on yellow fever virus, and they had some primates that were exposed to the mosquitoes, and they were able to describe this novel virus named for the Zika forest in Uganda. There were subsequent outbreaks in Africa, and eventually it made its way to Southeast Asia. And this Yap Island outbreak in 2007 was one in which epidemiologists were really able to study the bulk of the population and understand that serologically most of the population was exposed, but only about 20% of them had symptoms. So that's where we get a lot of the information about the asymptomatic Zika infections. There were subsequent outbreaks throughout Polynesia, but it was really when Zika virus entered Brazil that a lot of the concerns that we know about today with Zika congenital syndrome were understood. So here are some examples of the maps that we're used to seeing from the CDC. And these are periodically updated because once Zika entered Brazil, principally in the Northeast, it rapidly spread throughout most of South America, the Caribbean, and here in the United States, you'll recall that we had a few autochthonous cases here as well. In the Caribbean, it's also been a major outbreak that has affected many, many people in this part of the world. So in the United States, most of this map reflects returned travelers with Zika. And in New York and Florida, we were a couple of the states that had the most of those returned travelers. In terms of the U.S. territories like Puerto Rico and American Samoa, there were numerous cases that were local transmission, and I'll show you some of those statistics. Parts of southern Texas and southern Florida also experienced some local transmission. So this was the map of Miami in October of 2016 from the CDC, and they had a generalized warning for pregnant women not to travel to southern Florida around that time, in particular to a small area of Miami called Wynwood, as well as Miami Beach. And the last symptomatic cases that were found were in October, so since then they've updated the map, and really at this time there's no additional pregnancy warnings for travel to southern Florida. The map of Texas as well showed that there were some local transmission cases in southern Texas, but since then there have not been any local transmissions. And this was something that was sort of foreshadowed by what we know about dengue, because there had been a few cases of local transmission in Key West and in Miami and parts of southern Texas of dengue by the local Aedes aegypti mosquitoes. But these outbreaks tended to be very short-lived, and there was not a sustained person-to-person transmission. In terms of our statistics here in the U.S., there's been about over 5,000 cases. Most of those are travel-associated. But there have been some that were locally acquired. And Also importantly, there have been sexually transmitted cases, and that was a new mode of transmission in terms of our understanding of Zika virus, with a lot of implications for pregnant women again. In terms of the territories, there was a much more dramatic number here, over 37,000 cases, and a lot of our population here in New York City is going back and forth between New York City and Puerto Rico or Dominican Republic. So we want to be very aware of this ongoing concern for particularly for pregnant women. In terms of pregnant women in the U.S., there's over 2,000 in the U.S. states who are being followed and over 4,000 in the U.S. territories. And one of the questions that has been asked is to sort of get to a number in terms of the risk of congenital Zika syndrome when that occurs in pregnancy. And I'll show some data from both Brazil and other countries in terms of our estimates there. So PAHO, the Pan American Health Organization, is also tracking Zika cases by region. And I would say the overall news is good in the sense that there was a peak in early 2016, and that there seems to be a trailing off in the total number of cases throughout South America, the Caribbean, and Central America. Again, we're still concerned about pregnant women traveling to some of these countries based on the fact that it's reported cases, and a lot of those infections are probably happening asymptomatically. The link between Zika virus and microcephaly was something that was noted early in the course of the epidemic in northeastern Brazil, where they saw a concurrent 20-fold increase in the number of cases of microcephaly. The subsequent pathologic associations were made in a few different studies. There was a New England Journal article published in which some physicians in Slovenia actually had a patient who had gone to northeastern Brazil, was infected while pregnant, and then upon return had an ultrasound that had numerous abnormalities and decided to terminate the pregnancy. And the ultrasounds basically showed numerous calcifications. There was a disruption of the normal brain anatomy. The immunohistochemistry stains that were done really highlighted the intense inflammation that was present. And they were able to use fluorescence to find that there were, in fact, flaviviruses in the central nervous system, which they subsequently sequenced, and they were able to identify with EM that these flaviviruses were, in fact, Zika virus. And the strain that was present in this case was the northeastern Brazil strain, was one that was closely related to the Asian strains. So in terms of the transmission or the sequence of events of how this virus moved across the globe, phylogenetically it seems to be most closely related to the strains that were present in Polynesia. In terms of the link to microcephaly, the statistics were also important to understand because the strict definitions of microcephaly include a child's head that's below the 3rd percentile, and that had led to a little bit of confusion in terms of those statistics. But we now understand that this link is a direct biological one, and what we know about Zika virus is also that it's a zoonotic infection, and that we have non-human primates that are probably regularly infected, and then humans come into contact with those same mosquitoes and then become infected. And one of the questions that's still pending is the understanding of why this happened in Brazil at this time. And some of it is thought to be related to the fact that this was a very large outbreak with a very large naive population with constant exposure to Aedes aegypti mosquitoes. Some of it may have to do with some sort of a change in the viral capacity to be transmitted by Aedes aegypti to humans as well. The group in Rio de Janeiro, the Brazilian scientists who have been following a cohort of women who were infected during pregnancy, gave us a lot of insight into the question about trimesters. So one of the issues was, is it just a first trimester phenomenon, or is it a problem throughout pregnancy? And unfortunately, there were problems noted throughout pregnancy in terms of timing of infection. So that's where you got such a draconian recommendation from the CDC that women in any trimester avoid travel to areas in which Zika transmission was ongoing. the basic science of why this happens is also been studied, and Zika virus has been studied in the lab among human progenitor neural cells, and it's a very efficient virus at infecting these progenitor cells. So that finding is a helpful one to understand why it's such a sensitive time in brain development in terms of when that infection happens in utero. There's been a lot of concerns and questions about Zika virus testing, and that's, as you recall, evolved over the last 12 months since Dr. Weaver gave their grand rounds. And what we know is that there tends to be a short window of viremia for most patients. So that's less than 7 days for most of our patients. The urine may be a little bit of a longer window of detection. The serology, typically with an IgM, is useful between weeks 2 and 12. However, we're finding that some patients will have a longer persistent IgM, and that can also be confusing for women who are pregnant, may have been exposed to Zika at some point before their pregnancy, but may no longer have an active infection. Cross-reactivity with other flaviviruses is also a major issue. So that includes dengue and yellow fever virus. And for those that have been immunized against yellow fever, the utility of that serology is much more challenging because some of the tests need to be confirmed with plaque reduction neutralization testing as well. So I'll show you a little bit more about these algorithms, and it's just something that's come up a lot for us in the last few months as more and more people were returning from travel or had potentially been in areas of Zika endemicity and wanted to get tested. So they wanted to know if they were carrying that virus. And that was problematic because we had a lot of issues with false negatives with the PCR, which has a short window of viremia, and potentially with some of the cross-reacting antibodies with Zika. So when there is a positive Zika antibody, and this is nowadays mostly done through commercial lab testing in non-pregnant adults, this ends up sent out to our Department of Health eventually for them to do the plaque reduction neutralization test. And that tends to be a very time-consuming test, so anything that triggers an initial positive on the IgM ends up taking a long time for those results to come back. So we had a few cases here at Mount Sinai, and I just brought up one example. We had a 26-year-old woman with fever, chills, and severe joint pains. She presented 5 days after a 3-week trip to Guatemala, where she was there for a wedding. She had a lot of mosquito bites, and several members of her family were diagnosed with chikungunya. And we believe that was a clinical diagnosis and not a serologic or PCR one. She did have a new sexual partner in Guatemala, and initially she had no rash or conjunctivitis, really just the fevers, chills, and joint pains. But she returned to the ED 3 days later after she had had some initial testing, and you can see that she had this faint rash. It was very nonspecific, not really too dramatic. Really her joint pains were really what were bothering her the most. And then she also began to develop some other symptoms like severe nausea and vomiting, some abdominal pain, severe headaches. She was fortunately had a negative pregnancy test, had some elevated liver enzymes, and the serum Zika PCR was negative, but the urine Zika PCR was positive. So again, we sometimes will miss the viremia on the serum test, but the urine test was often useful a little bit later. Her initial Zika IgM was negative, chikungunya serology negative, and she had an equivocal IgG on dengue. So all of these serologies can be problematic in terms of exactly when we are catching the patient. And fortunately, she recovered very well from this initial infection. She was a non-pregnant adult. And then we started to have some conversations about Zika and future pregnancies. So that has been a subject of a lot of controversy because we have cases in which the Zika virus has been transmitted sexually by, in particular, men to women who are symptomatic can sometimes shed the virus for many weeks. So this led to some updated guidelines from our CDC and the MMWR that I'm showing here. And the basic message was that for most patients who were contemplating pregnancy and traveling to an endemic zone. If it was the woman traveling, we were recommending a waiting period of around 8 weeks. But for men traveling, we were recommending a period of at least 6 months. And that was based on some of the detection of Zika RNA in semen. And the reason this led to some debate is that some of these were non-culturable viruses, but they were genetic material that was found. And so I think the CDC had to find a waiting period that was reasonable for most patients. So that remains a 6-month waiting period for adult males, and for women who have traveled to an endemic area, an 8-week period. So in terms of the Aedes species in the United States, these are the vectors that we are concerned about, Aedes aegypti and Aedes albopictus. So the distribution of Aedes aegypti is really here in the southern United States, and they don't survive well in the winters of the Northeast. But Aedes albopictus is a vector that does survive, and we will find it present here in New York City. It's a less efficient vector for Zika and some of these other viruses, but it's a concern because it has served as a vector for this transmission. So what is the other ways that we've tackled some of the problems, in particular in endemic countries where there's been much more active transmission? The mosquitoes' aquatic habitats are very important for their breeding. So it turns out the water that's collected from rainwater for drinking or other purposes is a perfect breeding site for these mosquitoes. They need a sort of protected environment and fresh water to lay their larvae and their eggs. And these are the kind of sites that a lot of the public health workers were trying to help people eliminate so that they wouldn't have these Aedes mosquitoes present around their house. And they tend to have a fairly short flight span. So they only are flying around 500 feet. So that's why you had such a narrow square of concern there in Miami, because they were trying to track those mosquitoes in a very short distance. But also it speaks to the fact that they tend to live in close contact with humans. And that's where we want to eliminate a lot of these water supplies. So in terms of vaccine research, we have a few vaccines in phase 2 clinical trials in Puerto Rico, Brazil, Central America. There is a live attenuated dengue Zika vaccine that's going to enter phase 1. So a lot of what we know about flavivirus vaccine research is based on yellow fever virus, which we have a good vaccine for, but it's a live attenuated virus. And for a lot of these antigens, just switching up the antigens, we're always concerned about potential side effects. Here at Mount Sinai, there is a terrific group working on emerging pathogens, and I just highlighted a few folks here in that institute. Dr. Adolfo Garcia Sastre is a world-renowned virologist in influenza, and for those of you that saw the recent show Unseen Enemy on CNN, he and Dr. Palese were featured in speaking about the emerging threat of a potential flu virus pandemic with avian influenza. And Ana Fernandez-Sesma, her career has been fascinating to follow because she really got interested in dengue and then had to quickly evolve to chikungunya. And then in the midst of all the chikungunya trials in South America, Zika came on. So it's been an amazing scientific journey for her and her group. Jean Lim is also interested in flaviviruses like West Nile virus and Japanese encephalitis, so we have a group working on those viruses. And Viviana Simon, who's here in the audience, is one of my collaborators, so we've been talking about a personalized virology initiative in which we're trying to study the immune response in individuals to all of these viruses. So we're very interested in recruiting patients who have dengue virus or Zika virus or chikungunya, and understanding the way that their immune system individually responds to these viral pathogens. So we have some flyers here that Viviana's brought, and we're going to talk about hopefully recruiting more patients. As you see returning travelers coming back from these destinations, think about that study as well. So other causes of fever in return travelers, I always want to mention a couple of these because we focus so much on these zoonotic viruses that we want to keep some of these in mind as well. Malaria, typhoid, leptospirosis, rickettsial infections, and of course some of the locally acquired viruses like influenza and EBV, depending on the season. I think I just wanted to spend a couple of minutes on some case examples. So this was a 45-year-old UN employee who returned from a 6-week visit to his home country of Nigeria with fevers, diarrhea, headache, dark urine, and icterus. And you can appreciate the icterus here. He had quite an elevated bilirubin, all indirect, it turned out. And on the peripheral blood smear, you can actually find the answer to this case. So what we're looking at here is numerous infected cells with small rings, and they have a chromatin dot. And several of the cells have multiple parasites in one cell. They've got a few where there's a parasite pushed up against the side of the cell. It's known as an accolade form. And all of that is really helpful. But even if you don't know the finer points of these peripheral blood smears, just recognizing you have a sick returned traveler, you want to be thinking, could this be malaria? Okay, so malaria is the kind of infection we need to think about to diagnose, because our automated cell counters are not going to detect this organism. They're going to count the platelets and the white cells and the hemoglobin, but they won't be able to look inside the cells. And this is something you really want to be thinking about if you ever return travelers. So Plasmodium falciparum is our worst type of malaria. It's transmitted by the Anopheles mosquito. Anopheles is a little different than Aedes aegypti. It tends to be a nighttime feeder. So we think about prevention with bed nets and insecticide-treated bed nets, as well as clothing that's protecting us from the bites of these mosquitoes around sundown. This is going to cause the worst type of malaria because this parasite infects any aged red cell. So with some of the others, you'll see they're tending to be lower parasitemias. They infect reticulocytes as opposed to the any aged red cell. And this is the one where we really want to take action quickly. So if you're looking at a peripheral blood smear, you may see very numerous infected cells, and you may catch one of these banana-shaped gametocytes. And those banana-shaped gametocytes are a very telltale finding with someone with Plasmodium falciparum malaria. Now, in contrast, we had another case of a 35-year-old woman who was a physician, and she was working with MSF, with Doctors Without Borders, and was in the Democratic Republic of Congo for about 11 months. And while she was there, she had malaria several times. She had 3 bouts of malaria, and each time they were treated with artesunates. Now, artesunates are excellent anti-malarial drugs, but they really work at the level of the peripheral circulating schizont and not the tissue version. And I'll show you why that's significant. When she came back, she had a screening parasite smear that was negative, and her last bout of malaria was 3 months before her return. But a couple weeks after she got back here to New York, she started getting these fevers that were occurring every 48 hours. They came with some chills and body aches as well as headaches. And she felt sure it wasn't malaria because her prior episodes had been so much worse. All right? But here what we can see on the peripheral blood smear was that there were some infected cells. And besides the ring forms, we could also find some schizonts. And the schizonts are typically not going to be seen in somebody that has falciparum malaria. You can see that they have multiple parasites inside. This is sort of a developing asexual stage of the parasite as it's about to rupture open. And the infected cells tended to be a little bit larger than the non-infected cells. So again, that was a clue that we're dealing with a non-falciparum malaria. The fimbrinated appearance of the cell was also helpful in figuring out that this, in fact, was a Plasmodium ovale infection. So Plasmodium ovale and Plasmodium vivax are a couple of types of malaria that are very interesting because they tend to leave behind a dormant form in the liver. Okay? So even after you've treated patients with this type of malaria for their blood phase, for the circulating parasites, you want to be thinking about the need for an additional treatment with primaquine to treat the hypnozoite phase. Okay, so that hypnozoite phase, let's go back to med school for a second. Remember all of these cartoons that we memorized for step 1 and that we don't think about too often. But you know, when you have a returning traveler, it's useful to go back to this and see what are the steps that led to this infection. So typically, as we said, Aedes aegypti is the vector, and this mosquito takes a blood meal and injects a form of the parasite that's called the sporozoite. All right, the sporozoite enters the bloodstream, and it, in all of the species, will pass through the liver. So in Plasmodium falciparum, there's no kind of hypnozoite left behind, but it does have a liver phase. And because of that, there can be an incubation period between the mosquito bite and the time of symptom onset. All right, so symptom onset is typically once these parasites are rupturing open red cells. But before that, they've kind of developed into a tissue schizont, ruptured out of that hepatocyte, and they found a few red cells to infect. As they develop asexually, these are the typical rings that we're going to find on the peripheral blood smear. So that's the diagnostic phase that we're used to looking for. In the case of falciparum, as they mature into trophozoites and eventually schizonts, the schizonts are going to be adherent to the endothelial tissue and sequestered away in small capillaries of the brain, the kidneys, and the lungs. So we're not going to see them in circulation, but that's part of the pathogenesis of why falciparum is so severe. So the falciparum patients will start to get occlusion of circulation to their brain, and that's when you can start to see cerebral malaria. So if you have a patient with malaria who is starting to get altered mental status, that's someone who is in a very severe state in terms of malaria, and that requires intravenous antiparasitics. But in terms of Vivax and Ovali, they do leave behind that dormant hypnozoite phase. So even someone who has been treated with artesunates, in the case of this patient with Doctors Without Borders, and who has been treated for the blood phase, or who has taken prophylactic medicines, those prophylactic medicines like atovaquone proguanil, mefloquine, doxycycline, they're all basically acting at that blood phase. So they can still get a relapsing form of malaria because of the dormant hypnozoite phase. So it's important to keep that in mind because you may have travelers now at the end of the summer coming in with chills and fevers, but you could also have them in February. And you want to be still thinking about the possibility of malaria. Again, our cell counters are looking for numbers of cells. They're not good at looking inside of parasite blood smears. So we need our manual microscopists to do that. There are some new rapid diagnostic tests for malaria, and those are available for a long time throughout the developing world, and now have had FDA approval here in the US. So you might be using a Binax Now card to just look for the antigen presence. And those are good. We tend to rely more on microscopy because it gives us a lot more information about the percent of parasitemia, the species, and the severity of illness. So everything else that happens after this parasite develops and gets picked up by the next mosquito is the subject of a lot of research in terms of prevention, because we're interested in finding a good vaccine against malaria. Most of it has focused on the sporozoite phase, and that has to do with the fact that this is an organism that lives intracellularly for most of its life cycle, so it's difficult for us to develop good vaccines for something inside of a red cell or a liver cell. But this sporozoite phase, when the antigens are exposed to our immune system for a longer period, has been the target of a couple of vaccine trials. Unfortunately, they're not as robust as we'd like to see, so we're still years away from a very good, effective vaccine against malaria. In terms of personal protection, these are some of the basics that we talk about with our travelers, and they're useful in this discussion of malaria, but also for dengue and chikungunya and Zika. Basically, the mosquito nets that are used on safari are often going to have an insecticide treatment like permethrin. The DEET-based repellents that are useful for skin, concentrations of 20 to 30% are generally adequate. You'll see 100% DEET sold, but it's basically a duration of protection. And many people do find that the 100% DEET can be a little bit irritating. So those are a couple of the basics in terms of preventing a lot of these insect-borne illnesses. So in summary, I think the numerous recent outbreaks have demonstrated the speed at which zoonotic infections that cross over to human species can be transmitted globally. Vector-borne illness remain a major public health threat throughout the world, and understanding the biology of these vectors can be as vital to understanding the pathogenesis as our understanding of the biology of the virus itself. So I think those are the major issues I wanted to address today, but I thank you for your attention, and we can maybe take a few questions too.
Vaccines are evidently dangerous to pregnant women and therefore have been tested very little in pregnant women. Can you tell us which types of vaccines that are on the market now are dangerous to such women?
So I think the major theme we should think about with our pregnant traveler in terms of vaccines would be thinking about the live attenuated virus vaccines. And the most common question that comes up has to do with the yellow fever vaccine. So yellow fever virus is one in which we've had a vaccine for many decades now. It is a live attenuated virus vaccine, so it's avoided in pregnant women and patients with immunocompromise, including those with transplant. We have a little bit of data from those that have HIV with T cells above 200 in terms of its safety. But at this time, we're recommending it's avoided in pregnant women, for example. On the subject of yellow fever virus, we have a vaccine shortage that's coming up. And this has been a perennial issue for a long time. But it's a more severe one now because the major manufacturer in the US is shifting their production facilities. So for a while, we're only going to have access to European vaccine for a few centers. So that's something to be aware of if you're getting a lot of phone calls about people going to yellow fever endemic countries. At Mount Sinai West, Dr. Cahill is going to have a supply. But that's been a periodic interruption in supply that's gone on for a long time, and now it's going to be a bit worse as they shift their production facilities. But for pregnant women, that would be the main theme. So avoiding things that are live attenuated virus vaccines. A lot of our other vaccines like hepatitis A and B have very good track records, so we know a lot about them. The other major live attenuated vaccine we use for travel tends to be the oral typhoid vaccine. Typhoid is a preventable illness with food and water precautions for a lot of our travelers. For those that are immunocompromised, we tend to use the injectable version of it. And I think the other conversation we have, it's with the era of Zika, we've had a lot of pregnant women just defer travel to a lot of these countries. But it was always a concern when malaria was a possibility, because malaria medications often will have potential teratogenic side effects, and malaria tends to be much worse in pregnant women anyway. So it's a very important question too.
Yeah, one would intuitively think that soaking clothes in permethrin would be more effective than spraying. 15 years ago, I sent my kid to Ghana and I soaked the clothes in permethrin.
Yeah.
Now I spray it. Is there any?
I think the main difference will probably be the duration it lasts in the clothes. So typically you're getting probably somewhere around 6 washes worth of protection with spraying and 8 with soaking. So it is a little bit more effective, and it's just a matter of the practicality of soaking it.
In the Middle East, with MERS, the camel seems to be very important. You showed us in one of your first slides, spread to South Korea.
Yeah.
They don't have them except in maybe a few in zoos.
That's a great question. It's fascinating to look at these zoonotic infections and figure out what was the original animal that we think was the transmitting vector. So back with SARS in 2002, there was this palm civet that was in these animal markets that seemed to be the initial vector. In the case of MERS, there's been some debate as to camels or bats, and you're right that some places in the world don't necessarily have those animals, but can be a setup for transmission. And that happens when these coronaviruses are genetically mutated so that they're no longer just efficient at transmission among animals, but also human to human. And I think those are the events that happen in flu, which are so dramatic. So if you go back to 2009 and you think about the reassortment of that flu virus, it was a mix of swine, so it had some genetic elements from pig viruses, but also had avian flu and had human flu. So once that event happens and you have a virus that's able to transmit from human to human, then we can see the widespread transmission.
What is your response to travelers who are DEET naysayers? Probably reducing bites is the #1 thing you can do right now to protect yourself. So when you have people saying, I want to use, herbal remedies or herbal
Yeah.
treatments and things like that, what's your stock answer?
Yeah, it's a good question. Some people don't like the smell of DEET. Some people don't like the fact that it's a chemical. They don't want to, deal with anything that's not organic. So the CDC has done a good job of listing a few other alternatives. Probably the best studied has been picaridin, which is sort of a natural substance that does have good track record in preventing Anopheles and Aedes aegypti mosquitoes. Some of the other ones that are out there are not as effective, and you just want to, you'll see some other ones listed that you would just not trust, I would say. But I would say as an alternative to DEET, picaridin is the best recommendation.
Last month, there was a recommendation to consider travelers screening them for measles and actually vaccinating people for measles. Are you doing that for your populations?
Yeah, it's a good question. It comes up on our list of concerns for every traveler to go through their routine vaccinations, because we sort of got used to it, assuming everybody was immunized against measles and mumps and rubella. But I think a lot of these local transmitting events in Disneyland have shown that it's not the case. So it's certainly a conversation. I find that I tend to defer to the primary care physician in terms of doing the blood tests in terms of billing concerns, because so many years pre-travel visits were not covered. It seems like some insurance companies are getting better about it, so it may be the case that we're able to do more routine blood testing. And then chasing down immunization records tends to be a big part of the visit anyway, just trying to figure out when's the last tetanus booster you had and that kind of thing. But it's a good question, because measles has definitely made a big resurgence. Yeah.
Dan, I was wondering, do you change your counseling when people are traveling with families in terms of like younger age groups and very older age groups?
Yeah, we get a big, broad, diverse group of travelers. We do have a pediatric group that does a lot of our pediatric travel counseling. So, Michael Tosi's in our faculty practice taking care of kids under 18. But I think it does impact a bit of some of the conversations. Some of the younger travelers we do see going for a gap year, like an 18-year-old who's going to be off on their own in the middle of Africa, is someone that might be more likely to get a pre-exposure rabies series than someone who knows to avoid dogs and we're less concerned about their, or monkey bites, or So there's a lot of sort of implicit, basic common sense things that I think older travelers, we assume they're going to take responsibility for that, but for our younger travelers, not necessarily. And then in our older population, I think the geriatric population, we're definitely concerned more and more about making sure they've gotten the different types of pneumonia vaccine, since we've got a couple versions out there between the conjugate and the polysaccharide. And sometimes even basic flu vaccine, it's a chance to catch them up with those kind of things as well.
Please.
I'm a medical student from Kenya.
Oh, great.
And we see a lot of malaria cases.
Yeah.
And sometimes you're usually in resource-limited settings where you're not able to access diagnostic lab facilities. So is there a way to differentiate between Plasmodium Falciparum, malaria, and Vivax and Ovale at first encounter clinically without we having to wait for the patient to come back with recurrent cases of malaria?
Oh, that's a great question. I took out my card, Binax Now card picture. I think that's probably changed our diagnostic paradigm. So a lot of these antigen-based tests are able to tell us if this is a Plasmodium falciparum infection, a Plasmodium ovale or Vivax, or is a mixed infection, which has implications for treatment afterwards. Unfortunately, I think just on clinical acumen, we don't have that ability. And one of the issues that comes up is the fact that for our return travelers who have never been exposed to malaria, they tend to get very sick, whether it's falciparum or Vivax or ovale, because they don't have any baseline immunity. Whereas you might be seeing people who have had malaria before and have some degree of immunity and may have a little bit of a milder case. So it can be tough because they can have a falciparum but not feel as sick as, let's say, a traveler here who gets ovale and has just never had exposure to those antigens. So unfortunately, I don't think we have an easy way to detect them on first encounter, but the cards, I think, have changed the way that we approach diagnostics, because you don't need the microscope, you don't need the availability of a technologist to read the smear if you have those cards available. So I don't know, are they available to you in where you're practicing, or you haven't had access to those? So yeah, I think that it's hopefully part of the WHO's campaign is to make a lot of those type diagnostic kits a little bit more available.
One more question?
I've read that there was some concern with Zika that it's not just pregnant women and the fetus that's at risk, but perhaps like newborns as well. Do you know where they're thinking is?
Yeah, you know, I've been trying to get answers on this too because I get a lot of questions from young families that are taking their children abroad and going to the Caribbean or going to areas where Zika is still considered actively transmitted. And the best I think I could find was that, you know, those neural progenitor studies, those cells, a lot of that, you know, of course there's a lot of brain development that happens all throughout the years, but a lot of that, those cells have matured by around 18 months. I think most of the CDC pediatricians are still sort of holding out on a definitive answer because there's so much we don't know. So I don't think we have a solid answer on when it's considered safe for younger children. The pediatric cohort that's being followed is, the last time I looked, they were up to at least 162, but that was an age range from 6 months to 18 years. So most of those children were fairly asymptomatic and mild illness.
Let's thank Dr. Caplivski.